I would now like to show you a technique which possibly could increase our scope of practice in periodontics. And this is the rapid orthodontic uprighting of mandibular molars prior to implant placement. This is what we refer to as a proof of principle. We've only done a couple of teeth. Theoretically, looks like we have something that's positive, but much more research needs to be done before this becomes a clinically acceptable protocol. This is based on a concept that was presented by the Wilco brothers when they talked about PAOO, which is periodontically accelerated osteogenic orthodontics. Now, what they found, and this has been documented in the literature, is that you can get rapid accelerated phenomenon, which is RAP. Keep that term in mind. And this offers a window of opportunity, WOO, which allows 8 to 10 months for rapid movement before the window of opportunity closes. This is based on decortication, and I would like for you to note that this is not a corticotomy. The first cut is made between the teeth and apical to the apex to expose the medullary bone, which compromises the cortical bone. Then, if the bone is thick enough, you can see the perforations that are placed on the buccal plate, which allows for blood supply to bone grafting material, which is then added on the facial. Keeping that in mind, the decortication, we think in terms of a partial corticotomy. And this is an actual cut through the bone, but it is a partial corticotomy, which will allow for the rapid accelerated phenomenon and the window of opportunity that the Wilco brothers pointed out. This is our hypothesis. By the use of a partial corticotomy, the required time to upright a tilted mandibular molar can be markedly reduced. Here's the surgical protocol. Following a partial corticotomy, one of two types of controlled orthodontic mechanics can be used to either tip the tooth distally or to move the roots mesially. Following the corticotomy, bone grafts are placed in the corticotomy defects. Then additional bone is placed in the additional space mesial to the molars being uprighted. This bone grafting on the mesial is used to enhance site development for placement of an implant, and a bigger body implant can generally be placed. What is the clinical significance? First of all, this saves a molar or two if it is done bilaterally. Number two, it improves the site for implant placement on the mesial of the tooth to be uprighted. And number three, the patient receives two benefits from one surgery, that being the corticotomy cut plus the site enhancement on the mesial. And this is necessarily cost effective and time effective for the patient. The background. Preliminary data indicates that molars can be uprighted about 2.9 degrees per month with conventional orthodontics. And here we see three cases where this was done. On the 40-year-old, uprighting time was 17 months. On the 47-year-old, it was 13.7 months. And on the 46 years old, it was 8.9 months. But if you look to the right, you will see why the time difference on that. The greater the degree of uprighting, the longer it's going to take. And we uprighted 46 degrees on the 40-year-old, whereas we only uprighted 26.5 on the 46-year-old. And on the far right, we see the rate or degree per month, 2.7, 3.2, 3.0, or as we said earlier, about 2.9 per month. The cases we're going to present today on the 45-year-old, on the lower right, we uprighted 32 degrees, and we did that in 4.9 months. On the other one, the other side, on the lower left, we only uprighted 13 degrees in 4.5 months, 4.9 months. But you can see that this is markedly a shorter time and a lot more uprighting of the molars than we have with conventional therapy. So this is what we're striving for. Where did I get the idea to do this? This is a conventional case, and you will notice that we took out the third molar on the left as we look at it here, and conventional orthodontics to open up the space on the right took 13.7 months. Well, as I look on the left, it occurred to me, what if that molar was tipped and the first molar was missing? Could I not tip, or could we not tip that tooth back into the space? So that was the idea that we got for the molar uprighting. This is our experimental patient. This is David, who's a 45-year-old healthy male that we're going to do the proof in principle on. You will notice on the right, the space there between the second molar and the premolar is certainly inadequate to place an implant. That's about 5.9 millimeters. However, on the right, that space is 7.8, and certainly an implant could be placed there, but we're going to upright that molar slightly as well, since we're doing it on the right. Now, let's talk about the degrees of uprighting. You will notice on the right that the angulation of those is 59.4. And once we are through, it's a 26.5, which means that we have uprighted 32.9, which is significant uprighting. And we've created a space of 9.1, where the ideal space is 10, and certainly has improved the implant site, and perhaps a bigger bodied implant could be placed. On the left side, in all probability, this tooth would not be uprighted because the space is 7.8, and you actually could put an implant in there. So we're only going to upright that from a 7.8 millimeters to a 9.2. So we look at this, and the degree is only a 48.7 compared with a 59.4 on the other side. And once we're through, the final is going to be a 35.9, and if we subtract that from 48, we're only uprighting at 13.7 degrees. And the space created is going to be a 9.2, and ideally the space between the premolar, as we pointed out earlier, and the second molar is a 10 point. So the right side, you can see the space is very narrow. On the left side, you can see the space is wider, as we have pointed out. 5.9 to 7.8. The orthodontic movement, or the orthodontic mechanics, they're going to be two. The distal movement of the crown, which we can see one type of mechanical situation, and on the lower, another type. Whereas if we're going to move the roots mesially, we can see a different type of mechanics here. Distal movement of the crown and mesial movement of the roots. This is what we're striving for, and we're going to make, if we want to move the crown distally, we make the corticotomy cut on the distal. If we want to upright the roots, the corticotomy cut is done on the mesial. This is not a decision that we as periodontists should make. We should defer to the orthodontist and let them decide what type of mechanics they want to use. Then we will know where to make the corticotomy cuts. Now we're going to discuss something that you perhaps are not familiar with, and that's the FEA. This is the finite element analysis. First, we will show the initial displacement of the teeth with and without the corticotomy cut. Next, we will show the von Mises stress distribution in the PDL and the bone elements with and without the corticotomy cuts. That sounds like Greek at this point, but let's go look at what we're talking about. Now, even more Greek. We're going to use the 3D model, Young's modulus in Poisson's ratio, which is isotropic, literally elastic material. The blue indicates where the movement in uprighting will take place. Here we see the buccal view of a non-corticotomy, and look at the large amount of blue where pressure will have to be applied before the tooth can move. But once the corticotomy is done, notice that only in the apical area is movement going to be done, and a tipping movement can be done, which means that we can move it much more rapidly and with much less pressure. So when we apply pressure here along the blue line on the bottom, notice that the tooth actually pivots here, where on the left it has to be forced against a solid plate of bone. The initial displacement from the distal view. Look on the left, all the displacement that has to take place on the cortical bone, but look at the distal view, how little is going to be placed. It's quite obvious that the movement of the tooth is going to be easier on the right than it's going to be on the left. This is a mesial view of the amount of pressure that needs to be applied. On the non-corticotomy, look at the space where the force is going to have to be applied, whereas with a corticotomy cut, it is certainly much less. Simulated forces were applied at the attachment region on the bracket. Periodontal ligament experiences high stress level without the corticotomy and minimal stress level with the corticotomy. So the von Mises stress on the PDL model we see from a distal view, and the forces are distributed much more on the distal and more localized on the distal in the non-corticotomy. Treatment of the right. Now let's get to something that's not Greek and see exactly what we can do. So the treatment on the right. The first thing that's very important on here is the brackets are placed and the wire on the facial is placed before we do the surgery. Because remember, there's a window of opportunity of about 8 to 10 months, and you want to activate the treatment actually the day after the surgery is done or the day the surgery is done. And we see the space here, 5.9 millimeters. And the corticotomy cut in this case is going to mate on the distal. And you can see here that we're going to come about halfway down the root. Now this is an area where research needs to be done, for we don't know how far apically that needs to go. 50% between the crest of the bone and the apex, 30%, 60%. This is an area where much research needs to be done. The treatment on the left. The left, remember, the space is not that wide, and the bands, the appliances are in place, and we see that the corticotomy cut is going to be made on the mesial. On the right side, the side where we need most of the movement, you can see an x-ray of the actual corticotomy cut that we did, and bone graft material was placed in that area. On the second middle image, we can see 1 month later where we can see the rapid RAP, rapid accelerated phenomenon, because you can see bone is beginning to form there, and 4 months later, look at complete fill. Now that's an example of the RAP, and the window of opportunity is only 4 months, and remember the window of opportunity is from 8 to 10 months, so we're only going to use a partial amount of that. And I think it is quite obvious, 4 months later we've got a much better site for placing an implant. On the left side, remember that we only had to tip this 13 degrees, and we see on the mesial where the cut was made, did not go as far apically and did not go as close to the tooth as probably we should have done. And we can see 4 months later, the rapid accelerated phenomenon, the bone graft has filled in. And now, considerations. First, to capitalize on the window of opportunity, orthodontic forces should begin on the day of surgery. Second, in the current case, the corticotomy cuts were between 30 and 50% of the distance between the crest of the bone and the apex of the tooth. At this point, we do not know whether 30% is enough, 50% is enough, and as I said earlier, this is an area where we need to do considerable research. The right side pre-op. Note the TADs and brackets are in place at the time of surgery, so appliances can be immediately activated. Here's the corticotomy cut on the distal, and you can see that we're going down on the right. That cut is probably going down about 7 millimeters. Note the slight amount of bone on the distal of the molar to create an osseous defect and not a periodontal defect. The closer you can make that, but leaving a little bone, the better it should be. And you can see the perforations on the mesial and where a membrane is going to be placed to cover the bone graft material, and some tacks will be placed to hold the membrane in place. On the second case on the left, we're making the corticotomy cut on the mesial, for in this situation we want to tip the roots mesially, which will not make the tooth extrude. So a little different concept, certainly on an area which in reality probably did not need to be done, but from the experimental nature of this, we elected to do it. Again, the membrane bone graft are placed, and the post-surgical activation of the orthodontic movement, we can see an outline of the cut. 4 months later, on the right side, we can see the space that has opened up. And on the left side, even though the space was much less, we can see on the left that we certainly have a better site for placing an implant. The right side was uprighted, remember, 32 degrees, and we can see the pre-op and the post-op 4.9 months later. The left side, uprighted molar, remember we only uprighted 13 degrees, and we see on the left the post-op view, and we see on the right 4.9 months later that the rapid accelerated phenomena, the bone has filled in completely. Orthodontics completed on the right, orthodontics completed on the left, and now implants placed, and you will notice that wide bodies implants can be placed because the ridge is much wider than it was initially because of the bone grafting that we did on the mesial. So on the right side, we've opened the space up to a 9.1. On the left side, we've opened it up to a 9.2. And you can see the implants placed. Preoperatively, remember what it looked like. Postoperatively, look what it looks like with the 2 implants in place. And the occlusal view of the lower, and the right side and the left side, and we have done this patient a tremendous favor with a minimal amount of treatment. And this is the way our patient looks, not smiling, smiling, and the profile. I'd like to thank the people that are involved in this, Dr. Jing Zhou, Dr. Caleb Poston, and my webmaster, Jonathan Cheney, who did all the editing on this. As I said earlier, this is a proof in principle case. It offers an idea and an opportunity that may provide a procedure that can add to our scope of practice.